बोलिए स्टार्ट.
Good afternoon to everyone present here with us today. This is Trion from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Banshi Sahu. Sir is MD Internal Medicine, FSCE, PhD, RSSDI, Chief Diabetologist and Chairman of Diabetes Care and Hormones Clinic, TIR Ahmedabad. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is TIR, Future of Glucose Monitoring. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you. First of all, thanks IGCP for giving me this wonderful opportunity. What I am going to discuss in next 15 to 20 minutes, a very important topic. This time in range had become a future of glucose monitoring. I don't have anything to declare for this as far as finance is concerned for this particular talk. Just to start with, we know that DCCT was a trial which was done primarily in type 1 diabetes, but it's almost like 25 to 30 years before the data we have, that A1C had become very, very important tool of monitoring. Lesser the A1C, better is the control, and that shows directly related with the less complication. So you have a tighter glycemic control mean you have a persons with a tight glycemic control, less HbA1c, less the diabetes complication. And this necessity established the importance of HbA1c in our clinical practice. We all know that hypoglycemia is a limiting factor. Everybody would like to have a tighter glycemic control unless we don't have an hypoglycemia. So hypoglycemia was always a limiting factor for a tighter glucose control, whether you use insulin or sulfonylurea, which can lead to significant hypoglycemia. So we are always worried of hypoglycemia. So three pillars to manage diabetes. DCCT and UKPDS had explained us that chronic hyperglycemia is to be treated. Then came the picture of hypoglycemia. This is a limiting factor. And finally, we all understood that it's a glycemic variability. Other than a chronic hyperglycemia, even you reduce hypoglycemia, still the glycemic variability is one of the very important reason for diabetic patients to develop the complication. We have some data to support it that in type 1 diabetes, in type 2 diabetic patients, both diabetes kidney disease is probably because of a day-to-day glycemic variability. Not only a chronic hyperglycemia is reason for them to develop DKD, but we have a growing data to support that glycemic variability is also very important reason. Even this hypo and hyper is responsible for worsening the endothelial dysfunction that increase oxidative stress in people with diabetes, and that is also responsible for person for DKD. Glycemic variability is for end-stage renal disease. This is a 10-year follow-up of a patient with type 1 diabetes study, which shows the persons with more glycemic variability found to have more end-stage renal disease. It is also found to be in people with coronary artery disease because it is responsible for rapid progression of coronary artery disease. A1C, as we are doing since last 30 years, but it has own limitation. It reflects last 2-3 months of average glucose, but it does not pick up glycemic variability and no hypo and hyperglycemic events. It gives us information of last 2 to 3 months, but it nothing predicts about future glycemic pattern. Patient with same A1C may spend drastically different amounts of time, both high and low glucose level. So you may have two different type of patients with like 8 A1C, but all these patients are actually different. When you see their hypo and hyperglycemia, one patient may have early morning hypo, other patients may have early morning hyperglycemia. Hello, and they may have different type of sugar level also. Pachi baat kariye. Pachi baat karo. Pachi karo. Pachi. हाँ. So what is time in range? Time in range is when the sugar remains between 70 to 140. How much time in a day it remains between 70 to 140, that is important. Someone have time below range, that is hypoglycemia, and time above range, that is hyperglycemia. So time in range is an appropriate endpoint in a clinical research as a measure of glycemic control in people with diabetes. There are emerging evidence that suggests time in range is inversely correlated to risk of developing micro and macrovascular complication in people with diabetes. The A1C and time in range, there are multiple differences, but one very important that A1C gives you the average of last 3 months, while time in range gives you a continuous glucose monitoring which can be evaluated and it can be compared at any point of time. There are international consensus. I was lucky that I was part of this consensus on a use of continuous glucose monitoring to be used by all those patients who may be at the risk of hypoglycemia, on sulfonylurea, on insulin. All type 1 diabetic patients should be on continuous glucose monitoring, but definitely now even those who are not on any hypoglycemic agent for a better control of hyperglycemia, also they should be on continuous glucose monitoring. So this 70 to 180, that is what we want them in a time in range. There is an international consensus for type 1 and type 2 diabetic patients, they should remain more than 70% of the time in range, while those patients who are elderly, frail, more risk of hypoglycemia, still it is advisable they should have remained between more than 50% of the time in range with less and less hypoglycemia. The utility of CGM, you can understand even before 15 years, 2008, there was a data of JDR of CGM, which is talking in compared to DCCT because DCCT had shown the A1C of median from decreasing from 9 to 7.2. But JDRF CGM study, which is done after 25 years with the even older CGM product, the mean A1C reduced from 7.6 to 7.1, but the risk of hypoglycemia from 62 to it had become 20. And that's what very, very important, that CGM is not only having a better control of sugar, but at the same time, the risk of hypoglycemia also significantly decrease. We have a data to support for type 1 and type 2 both, that better a type 1 in range, there's a less and less complication. This is a 10-year data. We also have a data to show that 10% cost reduction by improving time in range, not only in type 1 and type 2 diabetes, that is again significant decrease. And on that, we have written one very important paper, a time in range should be urgently need even a target for type 2 diabetes. We all know for type 1 diabetes, but for type 2 diabetes also it is needed. The electronically, the CGM data can be captured with a very beautiful graph as a ambulatory glucose profile, and that will give you in last 14 days how patient sugar is actually moving. We have written also one consensus statement from India that how we should use AGP in people with type 2 diabetic patients who are on oral anti-diabetic agents, and those who can't afford continuously, even there can be a frequency of using it. May not be necessarily that they should use it every month or every 14 days. Still, they can do it every 3 months. That's what we can advise for them to use, a recommendation from South Asia. But these all three are very important components for monitoring. At this point of time, as I told you, everyone is not putting time in range or everybody is not on continuous glucose monitoring. So what we can say, they can intermittently use CGM, adding A1C and a finger testing, and all three are complementing for a better control. But the future will be definitely people who will be more on continuous glucose monitoring. A time in range will become a method of glucose monitoring. Let me explain you a case. A 58-year-old male, type 2 diabetes, 10 years on multiple oral hypoglycemic agent, A1C of 9.3. I'm sure all of you will agree that this patient should be on insulin as per the guideline, who is on a triple drug. This patient, we explained that yes, you are on multiple oral anti-diabetic agent. Ideally, you should be on insulin with 9 HbA1c above. But patient was not ready, so we put the CGM. First 5 days, we call the patient back, and you can see that all the sugar are high. We explained that yes, you should be on injectable. We put in all GLP-1 instead of insulin. We stopped DPP-4, we added GLP-1, and we added SGLT2. That's a fourth drug. And what we are seeing, the sugar started decreasing on the next day. Patient was calling us on every alternate day because self-monitoring was also returned to the patients, and from 4 milligram, when patient came on 10th day to us, the glimepiride dose is reduced from 4 milligram to 1 milligram. And then we stopped the completely glimepiride, and last 4 or 5 days you can see sugar still remain very good control with GLP, SGLT2, and metformin. So you know how important CGM even in type 2 diabetic patients who were otherwise as per the guideline with A1C of 9 plus, he should be on insulin. And you can see here this patient, we have stopped everything and patient is only on GLP-1, SGLT2, and metformin. American Association of Clinical Endocrinology, first time in 2020, they had put that CGM should be or considered as one of the important principle of comprehensive management of type 2 diabetic patients. To summarize my talk, HbA1c is a gold standard for diabetic management. However, it does not demonstrate a very holistic or very individualized glucose profile. Glycemic variability is associated with increased risk of severe hypoglycemia, diabetes complication, and reduced quality of life. Time in range provides a very closer view of person glycemic status and it aids in a better glycemic control. Increasing time in range has been shown to have association with reducing micro and macrovascular complication in people with diabetes, and international guidelines have now been updated to include consensus on CGM data interpretation. There is a need that beyond A1C, we have to think of putting the patient on CGM and probably a time in range for a better optimal diabetes management. With this, I thank and time in range, I can compare with Google map versus the physical map. So how you would like to go at some place, definitely in today's world, we would like to add the Google, not the physical map, that how will you reach at that particular place. So time in range is a more accurate metric in compared to A1C, which we are using in our clinical practice at present. Thank you. Thank you very much. I'm stopping here, sharing my slides, and if we have any question, I can answer for that. Thank you.
Uh, Thank you so much, sir, for your wonderful presentation. So, still now we haven't received any question yet from our audience. So, sir, any take home message before concluding, sir?
So one take-home message: those who are on insulin and those who can afford, they should put on continuous glucose monitoring at least. Those who can afford and if they can put on CGM, nothing like it. And time in range, we should try to calculate them in compared to getting A1C. If they are not ready to do it continuously, intermittent usage of CGM is also as good. But in that condition, we will use time in range, self-monitoring of blood glucose, and A1C, all three in combined position, in as a complementing to each other for a better glucose monitoring and a tighter glycemic control. Thank you.
Thank you, sir. Sir, we do receive one question from our audience, if you'd like to take that up.
Yes.
So, sir, the first question is: how do you address concern regarding the privacy and security of patient data collected by CGM device?
So the CGM data, device collection data, is actually, I can say it's encrypted. They don't share. It is, yes, without name. They can use the data, but not with the name individually. So that is already been done, and it is not to worry as far as data is concerned for that.
So, there is one last question. What emerging technologies or innovation in glucose monitoring are you most excited about?
One is that long-term glucose monitoring. At present, we have for 14 days. There is a insertion, and then they can use it for 6 months to 1 year. That is something is very exciting.
That's all
Ever
from our
since.
audience, sir.
Thank you.
Okay.
Thank you.
Thank you, sir. Thank you so much for joining us today.
Bye.
Thank you, sir.